Hello and welcome. The number of COVID-19 cases are now coming down in many parts of the country, India, though the cost has been high, as we know, and we are still counting or not counting, depending on how you're looking at it. Now, it's been known since the first wave, which is in 2020, that COVID-19 does create all kinds of complications, post-disease complications. There is a name for it. It's also called long COVID. And many people know about these symptoms, including fatigue, tiredness, breathlessness, and so on. What we're also seeing now, maybe in a more pronounced way, is a new kind of side effects, largely or maybe predominantly arising out of the kind of treatment that many patients have gone through, and maybe it's connected to the virus itself. One instance of this is mucormycosis or black fungus, which is affecting people recovering from COVID-19, so much so that Rajasthan, the state, has declared this itself as an epidemic as we speak. So what are we seeing here? What are the lessons that we can take away from these side effects? And how could people be more aware of what they could face potentially because of potentially the kind of medicines that they are taking today? So to answer these questions, I'm joined by Dr. Rommel Tickoo, Director of Internal Medicine at Max Hospital in Delhi. Dr. Tickoo, thank you very much for joining me. So tell us a little bit about the side effects like black fungus, which of course now people are beginning to understand what triggered it, and what are the other side effects, more importantly, that you are seeing either the early signs of or could be triggered potentially because of the kind of treatment that patients have gone through.
Well, to begin with, I'll tell you, indiscriminate use of steroids has led to such infections. We even saw it earlier in the first wave, mucormycosis, but not as many cases. Now, there are so many cases, especially in Maharashtra, Gujarat, for that matter. Even in Delhi, we're seeing increasing number of mucormycosis cases. Now, this typically is a very rare infection, fungal infection. You see this in the air, in the soil, everywhere. It's like a normal commensal, but it only causes disease in people who are immunocompromised, severely immunocompromised, especially diabetics, cancer patients, transplant recipients, coupled with the fact if their sugars are very high, not well controlled, and then they have a disease like COVID. So the combination of this critical COVID patients who are diabetics and are receiving steroids and not in the right dose and for a prolonged duration, this all together can put them at a very high risk of opportunistic infections. And in this case, mucormycosis, which is a rare fungal infection. Now, this is an infection which has a mortality rate of more than 50%. And there are 2-3 types. The most common is the rhinocerebral, where it affects your nose, sinuses, can go on to affect your eyes, your brain, and then there can be pulmonary mucormycosis, where you have involvement of the lungs. And then there's cutaneous gastrointestinal, which is not so common. Rhinocerebral remains the most common. And the features of that is basically any immunocompromised patient, especially in these times when a COVID patient who's immunocompromised is a diabetic, is having uncontrolled sugar, and then has some sort of nasal symptoms, don't pass it off as sinusitis. The index of suspicion should be very high because this disease doesn't give you time. So it is a rapidly invasive infection, and it can destroy all your tissues. Basically, the symptoms could be facial pain, headache, tooth pain, and jaw pain, blurring of vision, visual symptoms are there, double vision, and so on and so forth. If it's in the lungs, then chest pain, breathlessness, dyspnea. And the treatment is actually surgery. And if it's on the face, then you have to remove the involved tissue, which sometimes means if it's invasive, you have to remove the eyeball also. So very disfiguring surgery. On top of that, it has to be followed with high-end antifungal treatment, amphotericin B, which is expensive, which has to be given for a long time. But all this, the reason for these infections, as I said earlier, is indiscriminate use of steroids. Now, what are the indications of steroids in COVID patients is what we should know. And that's what I'm going to tell you now. So basically, steroids are life-saving. There's enough evidence in critical COVID patients who are having respiratory distress or having a need for oxygen, BiPAP, or ventilation. It is not indicated for those patients of COVID who are not having respiratory distress, are not having any kind of need for oxygen. So first week of COVID is the viral replication phase. That's when you have typical flu-like symptoms, fever, headache, body ache, cough, cold. That's not when you should be using steroids. But because you have very high fever, you keep talking to your doctors, you pressurize them, and because somebody who had taken
Right.
steroids got well, there is too much pressure on doctors also, and then the patients also self-medicate, and some of them don't even discuss it with their doctors and start taking steroids. And that's when your viral load actually will increase. Though it will temporarily mask your symptoms. The fever might sort of settle, it might give you a sense of false security that I'm getting better. But in 3, 4, 5 days, eventually you'll have very high fever, cough, respiratory involvement. And we've seen a lot of patients who took steroids initially, landing up with a bad pneumonia. The indication for pneumonia for steroids in COVID is actually in the second week when you have respiratory distress, when your need for oxygen is high, when you are desaturating, oxygen saturation is less than 93, and there is a pneumonia, you need oxygen, and then your inflammatory markers in the blood are high, CRP, D-dimer, procal, all these things have to be looked into, and at this ferritin, and at the same time your CT scan is showing moderate to severe pneumonia. So all this coupled together will give you an idea which type of steroid to use, oral,
Right.
IV. In dose is very important. Dose and duration. Now the recovery trial,
Right.
which was done in UK, just want to tell you this, that it showed that if given to patients who are in respiratory distress, they really benefit and mortality is reduced. But when it's given to people who don't have respiratory distress or need for, it can increase the mortality. So there it's recommended that it should be given only for 5 to 10 days. And the dose is also specific, low dose. But we are seeing much more
Right.
than that being used for a longer duration.
Right. So black fungus, just to sum up this part, is really something that people are contracting because it's already there in the environment, which is hospitals or intensive care units.
It's there in the air, soil, but it doesn't infect everybody. But it infects those people who are immunocompromised, as I said, diabetics who
Right.
have very high sugar levels is the biggest risk for developing mucormycosis. So COVID itself decreases your immunity. And then if you're immunocompromised, if you're a diabetic with chronic kidney disease, chronic liver disease, if you're a transplant recipient, if you've been on steroids for some autoimmune disorder, if you're a cancer patient, then whether you're a diabetic or
Right.
not, you receive steroids. Steroids increase your sugar. So high sugar is the basic risk for developing mucormycosis, and then you develop it. It's in the air. It doesn't infect everybody. You have to have those risk factors. You have to be immunocompromised, and it's not that it's in the air everywhere. It's seen in the soil. It's seen in the air. It can be a
Right.
commensal, but it doesn't cause disease. It only causes disease when it receives this sort of fertile soil, when coupled with like steroids, high sugars, immunocompromised, and then you take high generation antibiotics also for prevention of secondary infection, and then drugs like immunosuppressants like tocilizumab, which is a monoclonal antibody. I mean, that also increases your risk of opportunistic infections. And these mucosis cases are being seen in diabetic patients, COVID patients who have received high generation antibiotics, who have received tocilizumab, itolizumab, such drugs, and their sugar levels have been out of control, and they've been given steroids for a long time, which is not a recommendation, and in a much higher dose. So if you stick to the right indication for giving steroids in the right dose, right duration, then it's not a major risk, and especially if you sort of handle their sugars. So sugar
Right.
control is the bottom.
Right. So, in your experience, those patients who do not or have not been given steroids may not develop black fungus. Is that what you're saying? And does that
They
correspond with your
can
experience from last year as well?
No, they can still develop, but that's very,
They
very
can.
rare.
Okay.
That's very, very rare. Yeah.
Okay.
But mostly, if you see, it has to be diabetic patient who is on steroids or diabetic patient otherwise not controlled with or
Right.
without
So,
steroids.
right. So we did know this, and you're saying that we did know this from last year that patients could develop black fungus because of steroids, or did we not know that it was being caused by overprescription of steroids or overconsumption of steroids?
We knew that, but I don't think that we had such a huge number of patients who needed steroids in the first wave. Right now, in the present wave, the second wave, there were a lot of patients who were having lung involvement, early lung involvement. There were a lot of patients who needed oxygen, which basically means their lungs were involved. So the steroid use was also increased. And then some of them were not actually responding to the conventional dose of steroids. So you can't at times even blame the doctors for using high dose, because
Sure.
otherwise you're losing the patient. Now, the flip side is that the sugars go for a toss. Now you have to maintain a balance between the two. If you only look
Right.
at the sugars and opportunistic infections, then you might lose a patient also sometimes.
Right. Okay. So let me broaden the scope of this a little bit. So black fungus is one side effect that we are seeing caused due to over medication or over consumption of medicine. What are the other side effects that I mean, everything may not be as fatal, but could be damaging even in the near term or even in the long term. What is it? What else is it that we could have missed or are seeing right now for which we need to be a little more alert?
See, other than the side effects of COVID by itself, which can cause cardiac complications, myocardial infarction, arrhythmias, myocarditis, or stroke in COVID patients, which is basically brain involvement, or for that matter, deep vein thrombosis. We've heard a lot about these clots traveling to the lungs, pulmonary embolism, or any system for that matter, liver, kidney gets affected. These are the side effects of COVID by itself. If we talk
Right.
about treatment leading to
Yeah.
complications, then it's
Yeah.
mostly related to steroid use. And if it's not mycor is rare, then it has to be secondary bacterial infections, which are very common in immunocompromised or even otherwise very sick patients who are on steroids. So pneumonia, secondary bacterial pneumonia, over and above the viral pneumonia, which they have, and urosepsis, urinary tract infection, spilling onto the blood, causing multi-organ dysfunction. I mean, these are the secondary bacterial infections. And because apart
So
from steroids, as I said, we also give tocilizumab and all other drugs which reduce your immunity. So it's a fertile ground for getting invasive fungal infections and bacterial infections as well.
right. So if again going back to the extent that you can to wave one, what are the other let's say in order of let's say the numbers you've seen them. So assuming black fungus was one key side effect of medical intervention or over intervention, what else could be the number two, number three according to you from your experience alone?
From my experience, if I tell you, I haven't seen actually too many, fortunately, secondary infections. Very rare. So many patients we've treated. In fact, I've treated thousands of patients who were under home isolation. I'm not talking about the admitted ones.
Yeah.
And majority of them did not actually develop any fulminant bacterial infection. Some of them did develop UTIs because they were on steroids or they were diabetics, but they never landed, most of them never landed up in the hospital. So secondary infections, we haven't seen, and this is what many doctors have shared with me, that they haven't seen so many bacterial infections, secondary infections in COVID. It's almost always complications are mostly related to COVID, or then it's related to high sugars and then these mucor kind of things. Though bacterial infections are common, UTIs are the second common infections which we see in COVID patients, especially the ones who are on steroids.
Right. So you're saying urinary tract infection is definitely another potential or side effect that you're seeing today. So the other question, doctor, is that we are in the middle of May. The big surge that we saw was in April in the second wave. So is it possible that there may be other secondary effects of this medication that may come later? Or if you were to look at your experience of wave one, or as a critical care specialist, whatever you have to see or will see will really happen in these 6 to 8 weeks?
Well, if it's something like mucormycosis or secondary bacterial infections, then it has to be in the coming few weeks, 2 to 4 weeks. It can't be beyond that. But if you look at long-term complications, as you earlier spoke about long COVID symptoms, then it can be those. Fatigue is the commonest symptom, then followed by cough, chest pain, palpitations, dyspnea, anxiety, insomnia. The taste in the mouth will change, depressive tendency, and minimal exertion, mental or physical, giving you trouble. And fever also. Low-grade fever goes on and on for quite some time in certain patients, and they keep investigating it, but nothing comes out, and eventually on its own
Right.
it goes. So those are the
Right.
long COVID symptoms.
Right. Yeah. And long COVID as a phenomenon we are a little familiar with because obviously we've seen it in wave one as well. And I'm sure, unfortunately, a lot of patients will face it in wave two as wave two too. Now, the other question, doctor, is as we look ahead now, I mean, while the number of cases are fortunately coming down, but people are still going to be affected. What is it that people should be careful of? Because I think it does appear that many people rush to get medicated, have taken medicines which are necessarily, I mean, not necessarily the best medicines, particularly in a global context or what physicians from other parts of the world are saying. and also are, as you said, pressurizing doctors to give them something because they are panicked, their families are panicked, and it is understandable in some ways. But nevertheless, if they knew today that this is what could happen to them, particularly if they have those conditions, what would you tell them? And how would you guide them in terms of medication? Could you warn them, let's say, twice over, saying that do not take steroids because someone else could take them and maybe get through, but you stand a better chance or a worse chance of facing a post recovery infection or a post treatment infection?
Definitely, it's not one size fitting all. So what I would like to tell people is that in the first 1 week, there's actually nothing which really helps because there is no treatment. There is no specific treatment for COVID as of now. And whatever we use is based on anecdotal evidence or minimal scientific evidence. Now, even if we use doxycycline or azithromycin, which are antibiotics, or for that matter, ivermectin, there is hardly any evidence. Now, ivermectin, there was one recent study done abroad in US where they showed that, yes, it does reduce the progression from mild to moderate. But that's one study. There are many other studies which have shown that it doesn't really have much of a benefit. But there are 40 trials going on. So we don't know. But as of now, there is not much evidence, but we keep using it because there's nothing we can use. Azithromycin, doxycycline being used extensively, no role actually, if you ask me. But sometimes we do use because there's nothing else to use and because you feel that it might have a secondary infection also, or there's too much of sputum or whatever indication, secondary infection. So you use it. Though actually there's no indication. So actually you're left with nothing but paracetamol and supplements. Zinc, vitamin C, paracetamol is only thing you can use in the first week. And now there's a role of inhaled budesonide, which is an inhaled steroid, because now the studies again done in Oxford showed that it does prevent progression from mild to moderate to severe disease. So if used early on in the disease when you have upper respiratory symptoms for 10, 14 days, it does wonders. It does prevent. So that is something which we can use, inhaled steroids, but because they don't have those systemic side effects. But again, in 3, 4 days when the fever is sort of going up and things are not settling, under medical supervision, again, it doesn't have to be done on your own. Don't self-medicate. That is the
Right.
message which to go across. And especially when it comes to steroids, I'm also talking about antibiotics for that matter. Don't even take those. Don't take any drug without medical supervision. But when it comes to steroids, they have side effects. They might have minimal side effects, or the side effects might be only for a brief while if used for 5, 10 days, which is the recommendation. It might increase your sugar. But beyond 10, 14 days, then there are a whole lot of side effects. Apart from the fact that in the first week, if you use it, it can give you fulminant pneumonia, secondary infection. There are other side effects of steroids as well, which is basically weight gain and then psychological effects, then anxiety, panic attacks, whole lot of things which then long-term glaucoma, cataract, secondary infection. There's so many things which steroids do. So try not to overdo it. Do it only under medical supervision and when there's an indication. And then it has to be given in the right dose at the right time. And don't do it just because someone else in the family or some friend or colleague of yours was given a steroid. Don't follow blindly the prescriptions that have been sent to you on WhatsApp by them saying that, oh, this worked wonders for me. Your doctor doesn't know what he's doing. Please do this. And you do that. There are a lot of patients actually who don't listen to us, but they listen to their friends and family. They don't even think that the advice that we are giving is worth it, which is very sad. So people have to go with the medical expertise. They have to listen to go by scientific advice. You can't do what your friends and family are telling you to
Right.
do. This is COVID can get tricky. You can land in trouble. And given the situation that we are in, at least a couple of weeks back, even you might not even get a bed in the hospital. So you have to be very, very careful as in what you're dealing with.
Right. And particularly, as you said, if you have comorbidities like diabetes, you should be even more careful about not what
Yeah.
medication you take today, and particularly if you're in a hurry to get cured.
Yeah, even the diabetic patients are anyway high risk for all sorts of complications, or for that matter, cancer patients or patients who are on steroids for some other disease, because they are immunocompromised anyway. So they have to be extremely careful. It's not only mucor, even otherwise, their sugars should be under control because, as I said, it can lead to some other infection. And post the discharge, when they're discharged from the hospital, COVID patients, for the next 2 to 4 weeks, they have to be very careful. They have to keep monitoring their sugars. Or the non-diabetic patients who were on steroids, might not know their sugars might have gone up. So they have to keep monitoring their sugars for at least a month or two. They'll have to keep it. Because a lot of patients that I've seen in the last couple of weeks who've been discharged recently were non-diabetics are now having high sugars. Even the blood pressure fluctuates with steroids. The BP also goes up. And with COVID, we've seen a lot of fluctuations in the blood pressure. It usually goes up, and then you have tachycardia, you have high heart rate. And all these issues keep bothering you once you go back home, especially the fluctuations. And diabetic patients on steroids tend to have bigger fluctuation of blood sugars. It might suddenly go up, it might suddenly go down. So keep a track of all that. Keep doing your tests whenever required, maybe every week to 2 weeks, as has been advised by the physician. And then be in touch. You have to be at it.
Right. Dr. Rommel Tickoo, thank you very much for your insights, and thank you for your time. And I do hope to speak to you soon once again. Thank you so much.
Thank you so much for inviting me. Thanks.